All right. Hey, welcome back. If you are coming back from somewhere. So purpose of this video here is to lay down a bit of information about trauma in regards to paramedicine and EMS. This is made specifically for the 2020 Atlanta Fire Paramedic Program class, but I can see where it would help other classes of mine and any EMS student that is out there. I will share this video with. By no means is this going to be all inclusive. I mean, I'm not a trauma surgeon. I'm just street paramedic here from the Atlanta area. And noticing that there are some subtle differences in the way certain people do certain things based on what their state and local protocols are. So if there's any kind of discrepancy going on and you want to email me about it, I'll leave my information in the box below and we can definitely talk about it. And I can tell you why I would or would not be applicable here for my students in Georgia. But then again, we are getting them ready to take a national registry test. So, and I tell the students, like, when you take the test, you're not a Georgia paramedic or EMT, you are nationally registered. So whatever that scope of practice there is, you would need to adhere to that. So if there's an option for a needle cric or a surgical cric or an RSI or something that we don't do here in Georgia, you can do that. We do needle crics here, and that's about as effective as a screen door on a submarine, but better than nothing, right? Half of nothing will always be nothing. Half of something is still something. So hopefully in the next couple of years, we'll continue to grow more and more progressive here in Georgia and start to meet some higher industry standards and follow evidence-based medicine guidelines to have our patients have a better and more desirable outcome. So to start with, I will say this probably a lot today because I want to really ingrain it in any EMT or paramedic's head is that trauma is a surgical disease. And by that, I mean is that we don't need you being rescue Randy on scene. You cannot perform heart surgery or, splint bones or stop internal bleeding on scene. No matter how good of an EMT or paramedic you are, sometimes we just have to, understand that this guy really needs me to stop any bleeding that I see, keep his blood pressure to a point to where it can perfuse his organs and tissues and get him to a level 1 trauma center as fast and as quickly as possible. Here in the Atlanta area, we've got 2 level 1 trauma centers in the city that are amazing. I mean, Grady Hospital is probably one of the best in this part of the country, best trauma hospitals, bar none around. And AMC, they do a really great job with what they do, what they can handle, but they do have the best EMS snack room, so they're okay with me. So today I want to go ahead and share my screen and get this thing cooking. So a lot of these slides and pictures and stuff, I mean, I created and wrote some of this, and some of it I found on Instagram. I just took it from there, or Facebook, or a friend of mine's page that has information about this. I am no way trying to sell this or copyright, infringe anything. If there is any kind of problem with that, with anybody that sees this, please let me know, and we will definitely take steps to take it down. I'm not trying to take money out of anybody's pocket, but I think it was Pablo Picasso said that when you find out what your purpose is, you need to just find out what your gift is, give it away. So this is completely free. I'm not going to charge anybody for this, but if it does take money out of somebody's pocket, hey, let me know. I'll take it down. I don't want your kids not to eat or whatever. But this preparation, this video is definitely for current students of mine, possible future students of mine, and anybody that might just need a good refresher. So I'm prepping today for the trauma section of the National Registry. So first and foremost, trauma is a surgical disease. In the Atlanta area, we want to push for a 10-minute on-scene time or less. Is that always possible? No. Looking at the car right there, I mean, with the rollover right there, it's on the side of the bridge. I mean, that's a tenuous situation. Think about it. I mean, we'd have to stabilize that car and then possibly extricate that patient. That's going to take a bit more than 10 minutes. So in the perfect world, 10 minutes or less if it's possible, but as quickly as possible. When we talk about the metropolitan versus a rural EMS setting, you've got to know your zone, your hospitals, what can handle what. And if you're not sure, just call them. Give them a phone call. Hey, y'all handle this, this, and this, or should I take it up the road? I started off in EMS in South Georgia, where the closest trauma center was about an hour away. And it had the mindset of if it's a bad trauma and they need to go right now, I might have to fly them, which the flight services around there really appreciate that, because when we give them volume, they get to keep that base there. And when I started off, I was a rural paramedic. I wanted them to be there. So they would always tell us, hey, if you think you need us, call us. That counts as a call for us. And if you have to cancel us, then cancel us, but that counts. And we need the numbers. And I think a lot of them might still share that sentiment out there. I got my flight medic certification, 6682 FPC. I used it for some fixed wing stuff for a while, but I'm too big for the rotary wing helicopter. I really wanted to do that. That was my dream, but they prefer you to be under 220, and I'm 270 plus. Maybe one day, but I just love food. We'll see. So trauma is a surgical disease. Let's keep that in mind. So things that happen with these types of things, we need to add in when we talk about trauma, talk about shock. Now, most of the time when we talk about shock, we're talking about the hypovolemic shock in regards to trauma. It does not mean we cannot have obstructive shock occur because of trauma, or cardiogenic shock occur because of trauma, or even possibly distributive shock occur because of trauma. With hypovolume, hypo meaning low, volume meaning the amount in the tank, it could be an issue with what? We've lost fluid, we've lost blood, and that blood is precious. It carries with it clotting factors. It carries with it the volume that we need. It also carries with it what else? That's right, it carries O2, the red blood cells and the hemoglobin are carrying our oxygen capacity. So very important there. Cardiogenic, we're talking about a pump problem. The heart muscle itself, the engine is bad, and it doesn't have the ability to meet the output needs of the body. Obstructive, we're talking about something physically in the way. So we're talking about like a cardiac tamponade that's obstructing the heart from expanding and contracting like it needs to, or a possible tension pneumothorax where the pressure in the chest has built up to the point where it's putting pressure on the heart and great vessels to where it cannot meet the needs of the body. And the distributive, we're talking about either a septic patient, which is not normal for trauma, but it could happen. We're talking about an anaphylactic patient, which is not normal for trauma, but it could happen. I mean, if there's a bee fly in my car and I'm allergic to it, it stings me and I wreck. I mean, it could be this secondary to this, you know. But for the most part, we're talking about a possible neurogenic shock where we've lost the sympathetic tone, and we have now all that distribution, the sympathetic nervous system is no longer keeping everything tight, so the vessels will dilate out. So one of the things that's a problem for us in trauma is hypothermia. Hypothermia, we got old Elsa there. So my two daughters' favorite characters in the world, they love to sing Frozen stuff. So hypothermia is anything less than 95 degrees. They lose the ability to shiver. And it could present with an Osborne wave, also known as a J wave. Now, that's important to know for your registry and if you live in any type of cold climate, because it could manifest itself at the junction of the QRS and the ST segment. So here's the numbers you need to know for it. Mild hypothermia is between 89.8 to 95 degrees. Moderate, 82.5 to 89.7. And you have severe hypothermia, anything less than 82.4 degrees. All right, and that does put you in an increased risk for VFib. Now, VFib, if you are new to this or forgotten really quickly, is that when the ventricles are not contracting and pushing blood throughout the rest of the body, they are in fact quivering, twerking on everybody. So if they're doing this, they're not pumping out, they're not pushing blood to vital organs and tissues such as the brain, the heart, the lungs. So that is a problem for us in regards to hypothermia. So heat stroke, I'm just trying to cover all the bases here. So if it seems like I'm jumping around, I mean, I kind of am. So heat stroke, that's when the body temperature is too high. Patients have gotten too hot. And if you've ever vacationed here in the Atlanta area during the summertime, you will understand that it's very possible to have a heat stroke out here. Very possible to have a heat stroke. It gets really hot and muggy around here. I'm talking about some swamp booty weather. It is hot. Also seems we're in a lot more traumas in the summertime anyway. Everybody's irritated and they want to shoot each other because their temperature is high. So body temperature increases, vasodilation increases, sweating, and the body can no longer cool itself adequately. So perfusion is shunted from the core to the skin and muscles. There's an inflammatory response and possible organ failure. So heat stroke versus heat exhaustion. Heat stroke's bad. The first thing we're going to want to do is get them to a cool environment. I'm telling you right now, if you work for a service that's trying to get you to go in service without the ability to cool your ambulance for yourself or for your patient, that is not patient advocacy. And in the state of Georgia, I can tell you it's illegal. we have to be able to put them in a cooler environment, put cold packs in their core areas, such as their groin and their axilla. We need to cool them down. It matters. Rehydration matters. Air conditioning matters. Cold fluids matter. We want to bring their temperature down before they go to heat stroke. Heat stroke would be much worse. Now, some of the things that you need to know about Registry is heat stroke. Usually they used to throw out this sign or symptom to differentiate between the two, and heat stroke would be when they stop sweating. They don't have the ability to cool themselves anymore. All right, so this could be exertional or non-exertional. Just being out in the sun in this Georgia heat could cause heat stroke or heat exhaustion. So we need to get them cooled down and get some fluids in them pretty quickly. So making sure you know how to differentiate between the two and how to treat those two will be paramount for you as an EMT or a paramedic. So now we're talking about the types of shock. We kind of did this a little bit earlier, but let's make sure we're all clear on the subject here. So hypovolemic is due to an inadequate circulating blood volume. There's not enough fluid in the tank. Now, to be thorough here, I want to tell you that hypovolemic shock, most of us think about it as like somebody stabbed you and you're bleeding out, but you can be hypovolemic and because you have just had diarrhea and crapped yourself all day, or vomiting and not be able to keep anything else in. You can lose volume in a number of ways. What about a burn patient and those fluids shifting out of their normal spots to cause the patient to become hypovolemic? So there's tons of ways for hypovolume to occur. We need to be able to recognize these things and, one, treat them adequately for our patients we actually see, and two, deal with these problems in the way that Registry formats them to you so you can prove that you have the minimal standard competence you can perform as a paramedic or an EMT in the field. I listened to a Registry rep at an education conference a while back, and he actually told us, like, the myth is not true. We are not trying to fail anybody, but we were making sure that people are safe to work on other people. And I, as an instructor, kind of have a similar mindset. I won't release a student if I don't feel like I could let them go out there and that they might work on my children. That's a fact. If I don't feel safe enough that you could work on my children, my family, or your family, whoever's watching this, then we won't release you. I know there's a shortage of EMTs and paramedics nationwide, and here in Georgia, we're hurting bad. I mean, bad. Some extreme measures are being taken just to have a butt in the seat. And I won't get political about it, but some extreme measures are being taken. But we can't release people who are unsafe to work on other people. So, you know, this isn't like art appreciation class. And I'm not bashing art appreciation. I took it last semester myself. I actually ended up enjoying it. But it's a lower stakes type of education format. This is EMS. This is paramedicine. This is EMT 101. This is, hey, if you don't know what you're supposed to know, people could die or get hurt. And sometimes, even though Registry is the great equalizer, people can slip through the cracks. We've all seen, a lot of us have seen bad providers out there. I'm like, how did you pass? Oh my God. So the goal for you is to take this seriously and not skip any steps. Not hit the easy button. Make sure you're spending the time you need to do the right thing and learn this material and take it seriously. So hemorrhage, dehydration, some issues we could run into with hypovolemic shock would be hypotension, tachycardia, anxiety, confusion, altered mental status, you know, and some of the buzzwords we hear for Registry would be like pale, cool, clammy. Anytime you see certain buzzwords on a Registry style test, it's trying to trigger you to think of something and do something. So let's say you see the word shallow breathing. They're trying to trigger you to, hey, BVM, I need to provide tidal volume. There is a difference in oxygenation and ventilation, which we have covered in a respiratory video before, and also anytime I have the opportunity to tell a student that, I do. So there is a difference in the two. So what about cardiogenic shock? We're talking about, again, the cardiac output is not adequate despite blood volume being normal or adequate. So the problem is that the engine, the pump, is failing. It can be the result of a third-degree heart block, or it be a failing left ventricle, or a myocardial infarction. An MI or a heart attack or myocardial infarction would sometimes destroy tissue. If I take a tourniquet or a piece of string and wrap it around my finger, right, it will turn red, blue, purple, black, and die off, because all organic tissue needs blood flow, perfusion, and oxygen and nutrients, right? Your heart's the same way. With a heart attack or a myocardial infarction, that blood flow is being impeded by either lipids, fats, vasospasm, some way or form. And that tissue of the heart meat is getting inadequate perfusion. So it'll turn red, blue, black, and die off. And dead heart tissue cannot pump adequately. It does not conduct electricity. The cells in there are dead. It's dead meat. And we can usually see that in the form of a possible pathological Q wave on a QRS. We can see these signs from a 12 lead sometimes where we have ST elevation indicating the presence and possibly the location of an infarct. So the most common cause of cardiogenic shock is a MI. Now, differentiating between when it is shock. Shock is when we have hypoperfusion. Shock is hypoperfusion. Hypoperfusion is shock when we are not meeting the demands of the body. So I usually call it cardiogenic shock when that blood pressure falls, okay? So we're looking at hypotension, tachycardia, pulmonary edema. What would that be? Well, if the left ventricle is not pumping blood out at the rate and amount it's supposed to, then guess what we'll have? That blood will back up back into the lungs and cause pulmonary lung edema. Fluid will be in the lungs, and you can't breathe through water. You can't breathe through fluid. So anxiety and confusion and possible PVCs. It's maybe just me, but a lot of times when I pick up a cardiogenic shock patient or one that meets the criteria for one, that ventricle is irritated. And there's PVCs popping off, which is premature ventricular contractions. There's some irritated ventricular meat in there, right? Let me move this out of the way. So we got obstructive shock. Inability to produce adequate cardiac output despite normal blood volume and myocardial function. So everything's working like it's supposed to, but something is obstructing in the way. It's stopping you from getting to where you want to go. This can be from a pulmonary embolism, blocking blood flow going to the lungs. It could be from a cardiac tamponade, which is when the sac around the heart is filled with blood or fluid, and it will squish the heart and it will keep it from doing what? From expanding to contraction. And then it could also be from a tension pneumothorax. A tension pneumothorax is when there is air trapped in the pleural space in the chest, and that air is starting to build pressure and push the heart and the great vessels over. Some signs and symptoms will be what? Difficulty breathing. Could be another underlying issue, JVD, tachycardia, anxiety. We learn a lot of patho for being paramedics and EMTs. We learn like this much patho, but our treatment sometimes, at least in the state of Georgia, is like this big. This is why we have to perform assessments. We have to perform very, very good assessments. We do not perform exploratory medicine, at least my students do not, at least here in Georgia. We don't perform exploratory medicine. We don't do things because it might work. I'm not going to perform a needle chest decompression on a patient that might have a tension pneumothorax. I'm not going to do it observationally. I'm going to make sure they have signs and symptoms that and a possible mechanism of injury that line up with a tension pneumothorax. And if they meet the criteria for them, then I'll perform a needle chest decompression. I'm not going to do it all willy-nilly and stab somebody in the chest with a needle just because I think they may have one. So we treat what we see. We treat signs and symptoms as they come. And, you know, because again, we have limited diagnostic equipment in the ambulances, fire trucks, and whatever, you know, form of response you have. And a lot of it comes down to a systematic algorithmic approach that, you know, if this is going on, I do this. If this is going on, I do that. Now, I say that with a caveat of like protocols are meant to make the most minimum performer at least, you know, adequately working, right? It makes the people at least rise to the bare minimum. If you get stuck, you can pull out that old playbook and you know how to run the game. But for a high-performing paramedic or pre-hospital provider or EMT, the best thing you can do for somebody is to put words in there like maybe, but should consider these kind of words to give the paramedic and the EMT the ability to work in the gray. If you've been in classes of mine, we talk about learning how to operate in the gray area because there are atypical, A meaning without, type, situations that occur every day. There's not a book or a protocol written for every situation you're going to face on the ambulance. So you have to be prepared to think critically and always put the patient advocacy first. Do what is best for your patient. That way you can have a more positive outcome for them. Because again, the goal is to what? First rule of medicine, do no harm, and decrease mortality and morbidity. Give that patient the best survivability chance that they have. So other types of shock we're going to talk about, neurogenic, anaphylactic, and septic. So another section will be devoted to anaphylactic and septic, I promise. But Today, we're talking about neurogenic, where we have loss of normal vasomotor tone due to unopposed parasympathetic response. So let's say somebody has a neck injury, a spinal, and that spinal has cut off what? The sympathetic response. So this may be a bad analogy, but imagine that the parasympathetic and the sympathetic nervous system are working antagonistically against each other all day, and they hold the line. They maintain the homeostasis of the body. And when you dissever that spinal and injure that spinal cord, that thing's pop, the sympathetic nervous system pops off. And now the parasympathetic nervous system runs unopposed. It causes massive vasodilation, hypotension, bradycardia. So the heart's not beating fast enough to meet metabolic demands, because cardiac output is what? Heart rate times stroke volume. So the heart rate's now dipped. So we're going to have a decreased cardiac output. Massive vasodilation will occur. So I have the same amount of fluid in the tank, but the tank is way bigger. And if you know anything about making this real for firemen, that's like going from an 1.5 inch hose to a 5-inch hose. The pressure is way different, right? So we'll talk, that is neurogenic shock right there. Again, I'll save anaphylactic or septic for a more medical speech later. So shock differentiation. You need to know what type of shock and what area of shock they're in. Area might be a bad word, but what level of shock we're in. So they'll start off as compensated. Compensated meaning what? Their body's doing okay. Like they're in shock, but their body is compensating, making up for the difference in blood volume that they don't have. It'll respond with tachycardia. Okay, I've lost blood. So to meet the metabolic needs in my body, and I'm going to just increase the heart rate. All right, I'm going to increase the respiratory rate. I'm going to keep my blood pressure normal or elevate it slightly and increase the pressure in my system to meet the needs of the body. I'm compensating for something. All right, so the patient could also have lethargy, which means they're kind of weak, tired, and sleepy. Confusion, combativeness. Why would they have that? Well, possibly because they don't have as much blood flow going to their brain, right? So they're going to be like, whoa, what's going on, man? You'd be a lot cooler if you did. So that would be a problem they would have right there. Delayed capillary refill, it's cool skin. Well, delayed capillary refill and cool skin will be to what? Pale, cool, clammy, those skin signs, which tell us a lot. My advice is to always touch your patients, even though there's COVID and everything like that. You got gloves on. Make sure you're touching your patients. The skin signs will tell you a lot about them, a whole lot. So the reason you would have delayed capillary refill and cool skin is why? Because we're shunting blood. That's right. We're shunting blood to vital organs. We're in a shock mode. So now we've got decompensated shock. We were compensating, we were doing good. Now we're decompensating. I have run out of juice. I have gotten tired. My body's adrenal system and catecholamine response is running out. My ability to compensate has failed. Now I'm starting to go downhill. So the tachycardia will kick up. The heart's going faster. Confusion, unresponsiveness, delayed capillary refill, cyanosis, cold extremity. Now the blood pressure is decreasing. This is the difference again in compensated and decompensated. Blood pressure will be normal or slightly elevated with compensated. When we're starting to decompensate, the blood pressure will drop and start to go down. This is bad. You would really hope to have intervened by this point, but sometimes, man, we say around here in the South, man, if the Lord wants you, he's going to take you. You know, there's sometimes I could not get there fast enough and I could not put enough fluids in the patient to help them, because here in Georgia, we don't carry blood products. That's what the patient really needs. He needs blood products and not that poison pasta water that we carry. It's better than nothing, but over the years, we can definitely say that we have over fluid bolus patients to death. There's a lot of negative side effects just dumping that pasta water in these patients. What the practice we do around here now is that we will allow a permissive hypotension. I'm really only trying to get the blood pressure to be about 80 or 90 systolic, more like that 90 range. And I'm really just trying to make sure the MAP, the mean arterial pressure, is at least 60 or above. If you've got a MAP of 60 or above, you're doing good, which means, because MAP is actually a better measurement of if we're meeting in-organ perfusion goals. So I would definitely say that they need blood and they need it now. There are a couple of more rural services here in Georgia that are starting to carry blood products. And that's an amazing, great thing, but it hasn't made it here to the Metro Atlanta area. But these guys out here in the rural setting, if they can't fly a patient, they got an hour and a half, 2-hour drive. They're going to need the blood products. You know, we have a kind of spoiled here in the Atlanta area. Like if I have a really, really bad trauma, I'm at best maybe 20 minutes away from a level 1 trauma center. If I'm having trouble getting through the city. Late at night when there's less traffic, I mean 10, 15 minutes. You know, but I still have to extricate and do my treatments and get me some large bores and, you know, mitigate the circumstances best I can within my scope of practice. But, you know, it's not like these boys in the country. When I was in South Georgia, we had a haul. They couldn't fly. There was too many clouds in the sky, or if it was overcast or it was raining or something, it was on me, and we had to deal with that patient for an hour and a half. So there are some pros and cons to being along with that patient, learning how to go through the extent of your protocol, being a rural medic versus a city medic. Now, in the city, I get to use my high acuity skills a lot more. In the country down there, I would intubate maybe 3 or 4 times a year. Here in the city in Atlanta, there's been nights I intubated 3 or 4 times a night. So there are some pros and cons to both. I am so glad that I've got to experience both sides of the spectrum, being in the rural setting and working in the big city. And I have enjoyed it, and I've never regretted any of it. Never. So let's go to irreversible. Irreversible shock. This is the bad shock. What does the term irreversible mean? Irreversible means it ain't coming back. It's going downhill. We're circling the drain. They'll have bradycardia now. Severe dysarrhythmias will manifest themselves. Patient could go into a coma, pale, clammy skin, and then frank hypotension. Frank meaning it's going to stay right there. So we have to avoid that and hopefully not have our patients go there on our watch. All right, so we've just actually covered all this. This is just more information here for my students that have time to spend on this, because I send this lecture PowerPoint out as well. It's really covering everything we just talked about, but it's just giving you more words to it. Because some of you are visual, some of you are auditory, some of you are readers, and some of you are kinetic. Most people in the EMS field that are interested in this field, whether they know it or not, are kinetic learners. But I try and adhere to the VART teaching methodology, which is I try and give a visual, auditory. I'll give people the reading material that they need, and I also try and do a lot of hands-on lab stuff. That way I can meet everybody where they're at. So I'll leave this one here for any of my students that want to go through it, look at it, or whatever they want to do. What about soft tissue injuries? So this is the kind of traumatic events that we can run into. Puncture, penetrating trauma would be what? A puncture, somebody stabbed you. All right, you've been stabbed. Something sharp has pierced your skin. So with any kind of stab or puncture, when we can talk about knives, ice picks, sharp sticks, a shank made of chicken bones. I say it because I've seen it. I've ran calls at the federal state here in Atlanta and in South Georgia around Macon State Prison. And when I worked for Macon County EMS, and I ran stabbings with the most interesting things. So the first thing we want to do is check for exit wounds, make sure that it's not embedded. If it is a stabbed object and it is embedded and it's still in there, hopefully you remember this from EMT school, but if not, don't touch it. Leave it there, stabilize it where it's at. At this point, we're just trying to prevent secondary injury. I do not want you pulling out any stabbed, embedded objects. Leave them there. Leave them where they're at. That way that you cannot make things worse. That thing might be sitting on an artery or whatever. You pull it out, you can make the bleeding worse. So leave it. If it is a gunshot, make sure that there is no exit wound, or find where the exit wound is at. And I'm going to encourage you to be thorough. Be thorough. Make your trauma patients trauma naked. Take your fancy raptor shears or whatever you carry. I'll pick that up later. I always carry these, the old Robin safety boys. These are some amazing shears. I love these things. And the window breaker, I am not endorsing them, but I guess I kind of am. But this is what I carried. These were fantastic. I tried carrying those little air evac shears for a while. And the first patient that they didn't work on, it really ticked me off. I had to take out a pocket knife and saw his clothes off, you know, being careful not to cut him, of course. But it was in the winter months. It was a bad trauma patient. It was a homeless person. He had on like 7 or 8 layers, and then cheap, flimsy air evac shears would not cut through all that. But you know who can? Robin safety boards. These are some great shears. I had a pair of Raptors too, and they never failed me. And I think SOG makes a thing called para shears. I saw it at Academy. Fantastic. You need a good set of shears, even more so if you need to spend money on something. If somebody is going to give you a graduation gift and you get a choice in what it is, ask for a stethoscope, a good stethoscope. Shears, yeah, you need some shears at some point, but a stethoscope is even more vitally important to hear lung sounds, to hear gut sounds, checking for intubation, and also heart tones. So the most unlikely places you can find penetrating trauma gunshot wounds. I had a patient shot in the butt, and I just could not for the life of me. There was no exit wound, so I thought maybe it just stuck in there, but I saw bleeding coming from his toes. So, I mean, as I'm taking his socks off, because again, when you make people trauma naked, they are butt naked. Of course, after you've checked everything out, you can throw some sheets on to preserve their dignity, you know, as best you can, but I don't want you to miss anything. So I would hate for you to walk into the ER and miss something because you forgot to cut their clothes, or you didn't because whatever reason, and now you look silly in there because you didn't catch an obvious thing, and now the patient's in a worse situation because you didn't stop that bleeding. But I was in South Georgia, and this guy had gotten shot in the buttocks, like Forrest Gump, and the bullet had traveled through his thigh, through his calf, and it had popped out between his big toe and his secondary big toe there. And stranger things have happened, I guess, but shot in the butt, it traveled all the way through his leg meat, leaving cavitation and damaging all that tissue, and then it popped out of his, right there by his big toe. So I'm telling you to be thorough. My job nowadays is to advise you and to warn you of the perils and pitfalls of paramedicine. So that's a pitfall you can fall into by not being thorough. If we treat people like family, let's say you have a son or a daughter, and I pick them up while they're with me, that's my son or daughter. That is my family member. So how hard would you, a provider, fight for your family member? You wouldn't skip steps. You wouldn't take the easy road. You'd be very, very thorough. So your quality of care will affect their quality of life. So treat them like family, be thorough, head to toe, systematic. And then when you're done with that, do it again and do it again. LOC, ABC vitals, recheck interventions, keep your attention on them. A lot of patients don't suddenly deteriorate. Healthcare workers, paramedics, and EMTs suddenly notice there's people in the back playing on their dang Snapchat, not paying attention to their patient. And this is something that can be avoided. And it's your job when you're at work to be all at work. You know, none of that late night macking on the phone. Hey, here, how you been? Yeah, it's me. I'm at work. Shoot. Let's save that for after work. You've got a job to do. If she can't respect that, bro, she ain't the one. If he can't respect that, he ain't the one. Baby, you can do better. So be very thorough. So puncture, penetrating wound. Now, avulsion, we're talking about what? A flap of skin done got tore off. A flap of skin done got tore off. So you're going to want to clean that wound and try and put it back in normal position. Control the bleeding, of course, and the way we control bleeding is what? Direct pressure. Worst case scenario, we do what? We put a tourniquet on. So try and put that flap of skin back where it belongs, and then wrap it, and make sure that there's circulation still in the limb, if it's a limb or whatever. But before we do any kind of wrapping, splinting, or anything, we check pulses, motors, sensations before, after, and then again a little bit later. Make sure we haven't cut off the blood supply to any kind of tissue. So we do want to stop the bleeding though. So make sure the bleeding stops, bulky dressings there, keep it moist, and we'll keep rolling to the trauma center. What about amputations? Somebody got their stuff cut off. Amputations are interesting, to say the least. Seeing a piece of somebody's body laying over there like, oh, interesting, that's not normal. Make sure you take it with you, because there are surgeons out there good enough to reattach that thing, and they may not have too bad of a loss, right? So it's complete or partial loss of limb caused by what? Mechanical force, like cutting, shearing force. Apply dressing, use pressure points to control bleeding, tourniquet if necessary. Wrap the amputated piece in sterile dressings, place in a bag, plastic bag, and put it in a cold environment. If you've got cold packs or some way to keep it cold, then do so. But do not put that thing in water. Do not put that thing directly in water. Do not put that thing directly in water. It will cause a lot of issues with the blood inside there, the cells, and we don't want that for this patient. That might ruin any chance they have of getting that finger, arm, leg, foot, toe, whatever, put back on. So be very careful with that. Make sure you keep you bring it with you, keep it cold as possible, but you know, just do the best you can with that. Some more soft tissue injuries. We're talking about closed wounds. A contusion is a bruise. Contusion, ecchymosis, all that, it just means bruising. Now, this is a sign of internal bleeding. It could be just ruptured capillaries or something small underneath the hood there, but we want to be careful to understand that it could mean greater problems beneath that. If you've got a patient with a lot of contusion over their body and they just got pulled out of a wrecked car, and the blood pressure is dropping, the pulse is, and their tachycardia, the pulse is high, you got to bleed somewhere. Just because you can't see it don't mean it's not there. So any trauma patient you get, you're going to want to operate with a high index of suspicion. What does that mean? I'm going to treat them like they got the worst internal bleeding ever. Like the worst case scenario is unfolded in front of me until proven otherwise. You say chest pain to me, I'm treating you like you're having the worst MI ever until it's proven otherwise. And without soapbox, and a lot of paramedics think that they know how to differentiate between real chest pain and myocardial infarction and blah, blah, blah. Bruh, unless you got a way of measuring troponin levels on your truck, you don't know. Sometimes, yes, there will be ST elevation indicating a possible infarct in its location. I get that. But there's also sometimes where there'll be no EKG electrical changes. And that patient is sitting there just MI in a way, just heart tissue dying left and right. This is why I'll encourage all my students to 12 lead everybody. Why not? Again, if it was your family, wouldn't you want every diagnostic tool used? Wouldn't you want to be as thorough as possible? This is how you find things that patient didn't even know they had. Or when you go to that old lady who just like, I just feel weak today, baby. What's going on? Shoot. Oh, I'm going to just check you out, man. What's going on? I'm going to have my partner. Do you mind if you put these sticky things on your chest? I'm just going to take a look at your heart. Oh, my God. The 12 lead shows she's having an MI. No wonder she's tired. This is how you find things like that. So I'm telling you to be thorough from head to toe. Do a physical assessment as well, even on non-trauma patients. But why? That's more work. Dude, this is how you find patients that are unresponsive with insulin pumps or fentanyl patches or a wound on their leg that you wouldn't have seen unless you did a physical exam. And that wound is septic, and that's why they're altered. That's why they're burning up. That's why their blood pressure's in the tank. They're septic as hell. So be thorough with your patients. Be head to toe, and don't skip steps. All right, enough soapboxing. So with these kinds of closed wounds, expose, clean the wound, control bleeding, bandage as necessary, okay? Again, trauma is a surgical disease. And as far as what we can do a lot about it in EMS, I mean, we don't have a whole lot that we can do about it. We can stop it from getting worse, and we can, you know, help out in a bunch of ways, but at the end of the day, we're buying them time. We do save lives, we do rescue people, but I mean, this is blue collar work, guys. This is glorified blue collar work. Firefighting, paramedicing, glorified blue collar work. And I mean, I love it. And I'm proud to do it, but this is one of them times where you're not going to be the hero. The surgeon is the hero. Accept that, swallow it. Don't spend time on scene arguing with somebody about any kind of bull crap that's happened or whatever. Get that patient out of there. Minimize your own scene time and get them to the hospital. What if Joe Blow makes you mad on scene? You and Joe Blow can square up and talk about it like professionals after the call. But remember, the call is not about you, it's about the patient. And I promise you that they don't give a crap what color patch you got on while they're there. A lot of times, sometimes the city fire department and the city EMS service here in Atlanta, they get into, you know, pissing contests on scene. It is not necessary at all. It is not about you. That patient does not care what patch you have on. And this is common in tons of areas, like even in South Georgia, you know, it'd be like the county fire department versus the city fire department. Who cares? Treat the patient, fix the problem, and then y'all can worry about the nuances of whose big red truck can shoot more water later. So an abrasion is more like a scrape. The abrasion is more like a scrape, partial scrape, rubbing off a layer of skin. Expose it, clean it, control bleeding, and just bandage it if necessary, okay? Lacerations are what? Slice. Tear, split, incision, could be by knife, sharp objects. Size and depth could vary. The sharper the knife, the deeper it could go. So just be very careful with those and control the wounds, bleeding, clean it best you can. Don't be digging in people's wounds. We're not trying to give them our germs inside their wounds and make them infected, but clean around it. Make sure there's nothing going in there. If there's dirt in it, you kind of wash it out with some sterile water, but controlling bleeding is the main thing. Bandage the wound, not letting it get worse would be the main points there. All right, we've already talked about impaled objects. And for your registry prep, the only time that we would take an impaled object out, and I should have said this earlier, is if there's an impaled object that is in their cheek, face, or airway that we need to get out so we can maintain control or deal with their airway issue, or if it's a stab in the chest and the patient's in cardiac arrest and we need to perform CPR. I don't want to be doing CPR and that thing be just sawing away at their organs right there while I'm moving it up and down. So those would be the time that I would think of that you can want to talk about taking it out. Otherwise, do not touch it. If anybody can think of any other kind of instances, feel free to message me and I'll add it at some point or throw it in the comments or whatever. So hemorrhage classification, this is old EMT 101 right here, but it's still important to know for your registry. Make sure you're being thorough and checking all these things out. So when you're reading your registry questions, make sure that every word could matter. I hate to say it, but every word could matter. Remember, it's not an 80 to 150 question test. It's a 1 question test you take 80 to 150 times. Every word matters. Read every question. How many times? At least twice. Read the answers first, and then you know exactly what they're asking for. So hemorrhage classification, we got capillary bleeds, venous bleeds, and arterial bleeds. So with capillary bleeds, we have what? Slow, even flow, bright red color. It's coming out nicely, but it's just slow. It's more of an ooze that's kind of happening. Now, a venous bleed, it will bleed pretty good. Steady, slow flow, dark red color. It's going to just just flow on out. It's not oozing, it's flowing. Now, the big difference here in venous and arterial is what? If I hit an artery, it will spurt blood. It will be pulsating flow, like every heartbeat. So pulsating flow, bright red color because it has lots of oxygen in it, and it will be spurting blood. That's bad. Arterial bleed is bad. They can bleed out very quickly depending on the size of the artery nicked. That needs somebody to clamp that really quickly. You do the best you can and hope that the clotting cascade will help you out, but just make sure you know that is a very emergent situation now. What about the stages of hypovolemic shock? We've talked about compensated, decompensated, irreversible levels of shock, but now the stages of shock. So losing blood up to a certain point will cause you no problems. Up to a certain point will cause you tremendous problems. So stage 1, you've lost up to 15% of blood volume. Everything's normal though. Your body's compensating for that very well and you're doing good. Stage 2, 15 to 30. Mild tachycardia, blood pressure is still normal. You're still compensating. All right, so stage 3, 30 to 40% of your blood volume loss. Tachycardia is set in, blood pressure decreases. Now we're looking at what? That's right, decompensation. You're decompensating bad now. Stage 4 is when anything you lost more than 40% of your blood volume. Tachycardia is through the roof, blood pressure is on the floor. We're looking at some irreversible shock areas here. This is important for you to know because I've seen them ask this question of you at registry. And for you out there in the field, you kind of need to be able to, understand how much blood they've lost and kind of understand where they're at in the shock spectrum. It'd be a good tool for you to have and know. So the role of calcium in the diamond of death. So that used to be the triad of death, or what we used to call, I think, the triangle of death. They've added calcium because they found lately that it has a huge role in patients with trauma that die. So calcium has many roles. As we learned, it controls a lot of contraction, cardiac contractility. When we talk about the sodium potassium point, we talk about those calcium channels opening up and it having a lot to do with the contraction phase of the heart beating. It helps with muscular contraction as well, your muscles, vascular tone, and it helps with what? Clotting. Is that important for a trauma patient? Yeah. So low calcium in patients that become hypocalcemic early with blood loss, even before blood fluid administration, as they lose blood, they lose calcium, which is a crucial component in the clotting cascade. Clotting cascade is a bunch of things that have to line up. I'm trying to simplify. And if all these things are in order, the patient will clot. If there's not these things in order, they will not clot. So it has negative effects and worsens hemorrhagic shock and the lethal triad. So now it's the diamond, not a triad anymore. So blood products. These patients need blood more than anything else. Some services in Georgia, the 4 that I can remember, are doing the clinical trial for blood carrying. They're carrying blood. That's great. Other states may have been doing this for a while, but Georgia is a little bit behind here. So blood products, usually some O negative, are packed with citrate to extend shelf life. Citrate will bind to calcium to keep the blood products from clotting. So prior to administration, this is great for blood products, but bad for bleeding patients because it will interfere with their ability to clot. So what are the more problems of this diamond of death? Acidosis. As the body becomes more acidic, hydrogen ions bind to the sites that should be occupied by calcium, decreasing calcium's ability to do its job and assist in clotting, assist in cardiac contractility. So what's next? Hypothermia. Bleeding worsens hypothermia because that blood's running out, they're going to get cold. And hypothermia worsens bleeding. I eat because I'm unhappy. I'm unhappy because I eat. It's a vicious cycle. So hypothermic liver cannot metabolize citrate as well, worsening its negative effects and interfering with clotting. What about coagulopathy? I may have said that wrong. Coagulopathy. Coagulopathy. That sounds good. Why judge me? Calcium is crucial to the function of the clotting cascade and the platelets functioning. Without it, patients cannot clot adequately. So you see how these all kind of go hand in hand and work together. So this is the new diamond of death here. So we need to stop the bleed. In a nutshell, you need to keep your patients warm, get them to definitive care, which means what? To a trauma hospital, surgical hospital, right? All right, so give them the blood products if you carry them. It'd be nice if you did. Consider giving them calcium. I mean, we just got blood products in Georgia. We're probably not at the point where we're going to give them calcium. If it is, please somebody message me because I have not seen anybody's protocols about giving blood and calcium, but it is a great idea. I know other states might be doing it. But again, when we're taking the National Registry test, you are going to be working as a National Registry paramedic, so full scope for you. Evaluate for other signs of shock and then reassess. Let's talk about it. Major hemorrhage control, top priority. Patients can't live without blood. Blood does what? It carries oxygen. It gives you that life-saving oxygen. It carries nutrients and it perfuses your cells and tissues. So arterial bleeds can result in death in minutes, especially big bleeds. Like if you got a femoral artery cut, that's a big old artery. You can bleed out in just minutes. So aggressive bleeding control measures. What does aggressive mean? Well, if it's an arterial bleed and it's a femoral artery bleed, do you think that applying pressure will work? I'm not going to say it won't. Most likely, you may have to tourniquet that limb. That is invasive. That is aggressive. You might want to do that as early as possible. If I see an arterial squirt and bleed, let's just go ahead and put a tourniquet on. I'll, of course, write on the tourniquet because a lot of them have a little thing there, a little tab. You can write the time you put the tourniquet on. It's important for the surgeons and everybody to know how long the tourniquet's been on. So it's important to do that as well. Mark the time that it happened. So be ready with aggressive bleeding control. Tourniqueting if you need to. We teach a stop the bleed class here in Atlanta sometimes, and it has a lot to do with what? It has a lot to do with mitigating these hemorrhage control. So we teach wound packing, we teach tourniqueting the limbs and packing the junctions and doing what we can to stop blood from coming out. What about keeping the patient warm? It is very important. Cold affects their ability to clot. Now, what do you think all those cold IV fluids are doing over the years that we've been dumping it in patients? Also, cold will do what else? A big systemic cold in the body will cause a left shift in the hemoglobin dissociation curve, causing an increased affinity to what? Oxygen molecules. That means that they will just hold on to that oxygen molecule and not let it go. It will just hold on to it. So that means my tissues are not getting the oxygen they need. Another problem of just dumping fluids all willy-nilly into the patient. So keep your trauma patients warm, even in the summer. What about next? A MAP. We talked about MAP earlier, mean organ perfusion. A MAP of greater than 60 is what you're looking for. Anything below is inadequate for vital organ perfusion. Crystalloids are simply not helpful in hemorrhagic shock. They don't carry O2. They dilute the clotting factor. They're acidic and often cold. So blood products and surgery should be accessed as quickly as possible. Make this happen. All right, so we got the trauma thing of death, acidosis, coagulopathy, hypothermia, those things are kicking in. Some services here in Georgia are carrying TXA, which will assist in the clotting of the blood products. Here in this area, I think only the AMR units of DeKalb are carrying them. Last I checked, Grady wasn't. I know our Atlanta Fire guys are not. I think it's a great product and it can be very helpful. So tourniquets are helpful if you place them early and prevent a lot of blood from coming out. But we want to reassess and check the tourniquet for effectiveness and make sure that when you put it on that all blood bleeding has stopped and that pulse in that arm is gone, or leg or whatever limb it is. So that is how we talk about stopping the bleed. So keep them warm, definitive care, trauma is a surgical disease, blood products as soon as possible. If you carry them, great, put them in. If not, we just want you to keep the MAP 60 and above and keep that systolic 90 and above. Now, that's another problem. You just dumping fluids in there is that you could not only disrupt the clotting cascade, but if there is a clot forming and you're dumping a lot of fluid, it'll go in there, bust that clot that's already formed. So just be very careful just dumping huge boluses of fluids in these patients. All right, so what about blood transfusions do we need to talk about? Blood products, whole blood, packed red blood cells. Again, they got the citrate in there and that will stop calcium doing what it's doing. And we need to be aware of how to give these things. You need to follow your local products, but they need to be warm blood products. Most of the time, O negative is what most services are carrying. We don't have time to cross match and type blood. So O negative is the universal donor. It will do in a pinch. So that's what we would most likely give to these patients. I included this study here for my students. It'd probably be hard to read from the screen here, but this is from the GEMSA magazine, the GEMSA journal, the Georgia EMS Association journal. And it's really just going over Georgia's hospital blood product pilot. It's been a success. And I think Jackson County, from reading it, Jackson County was one of the first ones to actually give blood product in Georgia, and it was highly successful. I'm hoping other services around the state will pick this up and make it a more common practice here for us. All right, so fluids. We talk about fluids a lot, dehydration versus prenation, So when we do give fluids, we have options here. We got blood, if you carry it, which is great for carrying oxygen. We want it to be warmed. We have warmers for that. And we have crystalloids. The crystalloids we're talking about are what? We're talking about normal saline, lactated ringers, things like that. So high isotonic solutions are going to be the ones that have the same consistency of blood. Hypertonic would be more salty. Hypotonic would be less salty. So let's talk about it. Isotonic wouldn't change anything. You put that in the bloodstream and the volume just increases and nothing happens elsewhere. You put a hypertonic solution, a super salty fluid, into the vascular bed, and it's going to draw salt, right? It's going to draw fluid. Salt draws water. And water follows salt. So if I put a salty solution in that patient's vascular bed, it will draw all of that salt, of that fluid there. So it's, I know flight service in the past have used 3% saline to help deal with like cerebral edema. Or for some other reason, you'd want to put more volume in the patient's vascular bed. Great idea. Hypotonic solutions would do what? they would actually push fluid out of the vascular bed, right? The only hypotonic solution that we normally carry here in the Georgia EMS area would be the D5W. And what it would do to cells is, especially the red blood cells, would be to do what? It'd be to fill them out and make them, puffy and big. Sometimes they can get too big and they could lyse, they could burst, they could swell, pop. But we actually give this a lot to sickle cell patients in the hopes that it can deal with their pain that they're having, but also, get to those sickled cells and like change their shape back to a more normal donut-looking shell instead of that sickled shell. So making sure we know about macro and micro drips. A macro drip would be what? Allows for fast fluid resuscitation. That'll be a 10 or a 20 drop set. That's for just dumping fluids into a patient. That one's hard to titrate. And if you've ever rode through Atlanta, the potholes here will, just be nightmare on your back for one. But if I've got a drip going in and I'm like counting 1, 2, you hit a pothole, boom, they went like 10 drips right there. So they're hard to control. We usually give those for if we want to do fluid boluses or resuscitations or something. Micro drip is a 60 drop set. So that means it takes 60 drops to make 1 ml versus the macro drip, which is the big daddy, Mac Daddy. Macro drip, it only takes 10 drops to make 1 full ml. That's the difference in the two of those right there. Oh God, you had better know your Glasgow Coma Scale for Registry. And for any of these trauma hospitals around here, if you bring a trauma to them, they're going to want to know the GCS. Make sure you give them the GCS and it's accurate as possible. Now, I know a lot of you are spoiled if you've been in this area a while because your documentation software does this for you, but you won't have that option when you take your national registry. So make sure you know how to do a Glasgow Coma Scale. All right, chest and abdominal trauma. What are we going to do about it? So a flail chest, we're talking about that paradoxical motion. That was the buzzword Registry had for years. I'm not sure if they're still using it, but you need to be aware of it anyway. So asynchronous movement, paradoxical motion, the chest lacks symmetry when they breathe. Any one of those would be something to clue you in that there's a flail chest. That means that a patient has a section of rib somewhere on their chest that's broken off. So it's moving in an abnormal way, and it's very obvious to see. So the way we treat that now, they used to tell us to put big bulky dressings on it or like put a saline bag or something on. That was the old school way. Now we're treating it with what? Managing ventilations, keeping that O2 sat over 94%. You can consider CPAP and possibly intubation as needed, but what they really need is positive pressure ventilation. That is what all the literature says as of lately, is that they need positive pressure ventilation. So what about traumatic asphyxia, getting squished? Severe crushing to the chest and abdomen. It results in increasing the pressure through this chest area, right? So they could have blood being forced from their mouth, their nose, their ears, their eyeballs will sometimes pop out of their head, or at least have be bloodshot as hell because we've ruptured all kinds of vessels in there. If you got a patient who's been squished like that, you manage for shock, ABC, but you need to keep them alive and get them to the trauma center because that's the only thing they're going to need. So Commotio Cordis, we're talking about the blunt force trauma to the chest that would cause a patient to go into VFib. You have a cardiac cycle that follows, has an electrical output. If a blunt object, baseball, hockey puck, my fist, hits you at the right exact perfect time of your cardiac electrical cycle there, it could put you into a VFib, which means that your heart will stop beating and start quivering, and you'll be, dying and dead. So that is a thing that can happen. I don't want to throw that curveball at you in Registry and it not be caught by you. So what about crush syndrome and compartment syndrome? So crush syndrome is what? Something has been crushed. Something has been just squished on you. So traumatic rhabdomyolysis could follow. So what is rhabdo? I actually had that question on my Registry many moons ago. Rhabdomyolysis is what? There's been destroyed muscular tissue and it's released myoglobin that's gone and clogged up the kidneys and damaged them, causing acute kidney failure. The patient will be peeing out this brown pee and they'll be sick as a dog. So anytime blood flow is cut off to an area of skeletal muscular tissue for a while, that tissue becomes It goes into anabolic metabolism. There's lactic acid. Potassium levels start getting leaking out of the cells. Myoglobin starts running around, and it's crushed. So they become acidotic, hyperkalemic, and the big fat myoglobin is going to clog the kidneys, and it's going to cause kidney failure. It's going to cause kidney failure. How do you mitigate that? Rapid cardiovascular collapse. Prepare for that. How do you prepare for that? I'm putting pads on you because you might just be about to code. Okay. You can mitigate those issues above via calcium, fluids, albuterol, and bicarb. All right. So the calcium for what? The bleeding that might still be happening. What else could happen? Fluids to get that stuff that myoglobin circulating around. Albuterol to do what? Well, albuterol actually, if you give a high dose of it, can actually help move potassium back into the cells. And calcium will be cardioprotective as well. Giving a patient calcium will be cardioprotective. What is that going to do? If they're about to head towards VFib because they're hyperkalemic, calcium will be cardioprotective. It will also, the albuterol and the bicarb will help to move that potassium back into the cells. So, what about acute compartment syndrome? It may accompany a crush, but this is when that muscular fascia, which is that little thin connective layer, it's like a sausage swelling in a casing. It is squishing the microcirculation in their muscles, and it's damaging, and it is causing some decreased perfusion in that limb. So they could have pain, pallor, paresthesia, numbness, tingling, but they're going to need probably a fasciotomy to fix that. What does that mean? They open the patient up, they cut the muscular fascia, which is again squeezing that circulation going to the tissue in that area. I'm pointing my arm because if it was happening to my arm, I'd be cut open and that muscular fascia to be sliced so that pressure can be released and I can have blood flow to my tissues like I need it to be. All right, so we've already kind of covered crush syndrome. This is just another little covering over it just to make sure you're clear on it. You get a patient with crush syndrome, be looking out for acidosis, hyperkalemia, renal failure, and myoglobin release. So whenever something is crushed, remember it's squished and there's no blood flow to that area. What's going to happen is that tissue that's not getting blood flow, cells die and potassium leaks everywhere, and there's just a bunch of toxic stuff that's floating around there. And as soon as you move that object off of them, there are patients that have had that if they've had that crush going on for a long period of time, then all that toxic stuff will go straight into the rest of their body, and it could cause a very quick cardiac collapse. So IV fluids to keep the kidneys flowing, bicarb to fix the acidosis and to deal with the hyperkalemia. Albuterol will move the potassium back into the cells, and one more time, no, I'm repeating myself, but calcium stabilizes cardiac membranes and will help them not go into VFib. So, all right, about skull and spinal cord injury. We talked about this a little bit earlier with the neurogenic shock, right? The neurogenic shock patient is the one that had a spinal injury. But is it always a patient that has a neurogenic shock with a skull and spinal cord injury? No. Somebody can get cracked in the head and have just a depressed skull fracture and an increase in cranial bleeding. We need to talk about that just a little bit. So the structure of the skull we need to talk about are cranium, foramen magnum, cervical, thoracic, lumbar, sacral, and spinal coccyx. So there are 7 cervical vertebrae, 12 thoracic vertebrae, 5 lumbar vertebrae, and then 5 sacral vertebrae that are fused, and 4 coccygeal vertebrae that are fused. So the way I get students to remember that is that we have breakfast at 7, lunch at 12, we have dinner at 5, then we have dessert at 5, and then we have 4 margaritas after, just in the night. So dinner, so we have breakfast at 7 cervical vertebrae. We have lunch at 12 thoracic vertebrae. Dinner at 5 lumbar vertebrae. We have dessert at 5 as well. We have 5 sacral vertebrae. Then we drink 4 margaritas because there are 4 coccyx vertebrae. If that helps you, then great. If not, find your own thing might work, whatever. So other things we're talking about is the meninges. They're ability to pad the brain. These are the inner layers that pad the brain. So we have also this is where meningitis would come into play, and Registry loves to throw meningitis at people. But anytime you see the term nuchal rigidity or stiff neck, headache, fever, something like that, be thinking meningitis as a possible cause. So pia mater being the innermost, most delicate layer. You know, I think of pia as in like it, I think it means small or something. So pia as in tiny. Arachnoid mater, meaning the middle layer, web-like arachnoid spider. He's the middleman. All right, and then you got dura mater, which is durable, the outermost layer. It's durable, it's stronger. So dura mater and pia mater, I remember the easiestly, most easily, that's it. And by process of elimination, if you have trouble with arachnoid, then just remember that pia is the smallest, dura is the most durable. He's the outside guy, and the arachnoid guy is the middleman. All right, so what about autoregulation? So there is, the Monroe-Kelly doctrine states that there is a fixed volume of brain, blood, and cerebrospinal fluid in the head. And if anything changes that relationship, the patient will have increased intracranial pressure. Now, you have to have blood flow to your brain. If you go more than 10 seconds without blood flow to your brain, you will pass out. We have to maintain our cerebral perfusion pressure to maintain consciousness. Now, when we have increased intracranial pressure, one of the first things that will happen is autoregulation of blood pressure will be a compensatory mechanism to do what? Our blood pressure will increase. The systolic will start to go up. And that will cause pressure. The pressure will go up so that we can have blood flow to our brain, because as the brain swells or there's more pressure in the dome up here, it's harder for that blood to get through to the brain. So that increased pressure forces it through. Oh, nasty symbol, but it forces it through to the brain so it can get the blood flow that it needs. And the patient could exhibit signs of a Cushing's reflex. And the Cushing's reflex would be what? We have increased systolic blood pressure, widening pulse pressure. We got bradycardia and irregular respirations. Now, again, I'm not a neurologist or anything, but in my experience, being just an old street medic, the Cushing's triad they're getting you to look for is increased systolic blood pressure, widening pulse pressure, because the widening pulse pressure is what? The systolic and the diastolic are normally expressed as a fraction. They're normally kind of close, right? But the widening pulse pressure is what? They're starting to separate. There's a wide gap between the systolic number and the diastolic number. So the widening pulse pressure, increased systolic blood pressure, the bradycardia will occur. And the last one, the irregular respirations, they can present as chain Stokes, as Bites, as ataxic. I'm going to tell you right now, maybe it's just me, but it was always extremely hard with my head injury patients. Like, they have the other signs and symptoms, but it was really hard to see kind of what respiratory pattern they were in. So the ones you need to remember, of course, would be irregular, chain Stokes, you know, will be that crescendo, decrescendo period of apnea, ataxic, Bites, you know, just some irregular respiratory pattern will lead you to think that there is a, you know, increase in intracranial pressure issue. Now, the patient will probably have other signs and symptoms too, like probably some anisocoria, which would be unequal pupils, maybe some fluid leaking from their ear. And that fluid leaking from the ear, while it's a bad thing, it's not that bad a thing. It's the body trying to get that pressure down in their head. Because I've seen them in sometimes like drill burr holes in the skull to allow pressure out. So this leaking from the ear to the nose, I mean, bad sign, but it's also like, well, I'm just trying to compensate. So I'll allow it. But again, I in the field, sometimes I couldn't really, it was hard to differentiate between which one exactly is going on. When I gave a report to the ER, hey, he's got possible signs of Cushing's reflex. I mean, he's got systolics high, widened pulse pressure, bradycardia, and he's got irregular respiratory pattern. Because I don't know if you've ran many calls on the Highway 75 here in Georgia, but here in Atlanta, it is loud. I mean, that's why I'm telling you, buy a good stethoscope, because sometimes just even hearing things over the highway, the fire department's truck, your truck crunked up, I mean, it's hard sometimes. hearing breath sounds and, differentiating between these respiratory patterns, it can be difficult. So what about coup versus contra coup? So very familiar term here with a lot of EMS education. And so the coup is when the patient is slung forward, they hit a fixed object and they damage the front of their head. Now, as he hits forward, right, his brain will slide forward, slap the front of that skull, and then as he falls back, the back of his brain will hit the back of his skull. That is contra coup. So coup, bang, contra coup, bang. That's about as simple as I can make that one. So some other signs of increasing intracranial pressure, they have changes in LOC. Their eyes will have some changes, like again, of course, the anisocoria or unequal pupils, headache, decreased motor function, changes in speech. Vomiting is actually really bad. For infants, you'll have bulging fontanelles being a tall tale sign for them. Suture separation, increased head circumference, very high-pitched cry. But the posturing thing, right? So when we have posturing from a patient, that is usually a sign of herniation or a brain lesion going on there, right? So the increasing intracranial pressure has reached a point to where their body is trying to compensate for the increase in intracranial pressure. It's trying to force the brain through the foramen magnum, which is that tiny hole at the base of your skull. So herniation is bad juju, right? So we got decervate versus decorticate posturing, right? So decorticate is be what? Towards the cord. It's when they're posturing inward like this, right? All right, so decorticate, they're toward the cord. Decervate, that's a later sign. Their arms are spread out like this, and they're trying to grow wings and fly to Jesus, because that is a much later sign, and usually a sign of impending death. And then, of course, I've seen a few other C's. So we talked about ICP changes, Monroe-Kelly doctrine, expanding mass inside the cranial vault, displaces CHF. We done covered that, so we'll skip. We done talked about Cushing's triad a little bit. So you must know Cushing's triad if you want to pass registry. So normal ICP range is between 10 and 15, know that. You're going to want to keep the SpO2 over 94%. And a lot of times, if these patients are bad enough, you're probably going to have to intubate them. You're going to monitor their capnography at 35 to 40. If there is evidence of herniation, if they are showing signs of brain herniation, and you want to assist them, we have what is called the therapeutic hyperventilation protocol. Now, I can only tell you that some places may have stopped doing this, but here in Georgia, we have not. So what do they need again? They need blood flow to the brain, right? They need blood to go to their brain. So I need to increase their pressure a little bit. So CO2 is very vasodilatory. So we would blow off a little bit of excess CO2 in a controlled way to cause more vasoconstriction, to increase the pressure in their system, to give them more blood flow to their brain. The number you're looking for will be between 30 and 35. The number you're looking for your therapeutic hyperventilation, where you're blowing off more CO2 than the normal range, will be between 30 and 35. So again, 3 ways not to kill your traumatic brain injury patient. And I'll give I don't want to know if it's a shout out, but I got this from Instagram. You can probably tell from the format, but there's a flight medic on there named the Pre-Hospitalist, and she got some fantastic information. I saw this slide. I thought it was fantastic. I decided to use it. I don't know if it's some kind of copyright thing or whatever. I'm just not versed in that very well, but if there's a problem, I will definitely take it down or take it out or whatever. But I just love the information she's putting out, and it correlates with my teaching methodology. So if you have an Instagram and you want to follow her, it would be a very good idea, because she's got some great information and a pretty good unique perspective as well. So increasing intracranial pressure, the things you want to avoid: hypoxia. Hypoxia causes cerebral vasodilation and edema. It will increase ICP if we have that go on. Edema will be more swelling up there, more fluid that doesn't belong. So do not let that O2 sat slip below 94%. Hypercapnia. Avoiding hypercapnia, meaning high CO2. We just spoke about the therapeutic hyperventilation, right? We did that to do what? To decrease CO2. Do not let patients have high levels of CO2. So why? Hypercapnia leads to cerebral vasodilation. It increases ICP. Our ventilation goals are to do what? Titrate low normals, 35 to 30, to induce slight vasoconstriction and decrease ICP. Now, again, this is not a fix-all. This will help, but it's not going to fix everything. What do they need? Brain surgeon at your level 1 trauma center. They don't need you. So you need to be doing this en route or whatever. Get out of there. You're also going to want to avoid hypotension with your intracranial bleed patients. Your TBI patients, avoid hypotension. Why? So MAP minus ICP equals cerebral fusion pressure. We have to maintain cerebral fusion pressure. So we need it to be at least at 60. Normal MAP is running 70 to 100. So normal ICP is 0 to 10. So even a normal blood pressure and the pressure of ICP can diminish brain perfusion. For example, a patient with a MAP of 80 and an ICP of only 30 has only a cerebral perfusion pressure of 50. We're going to need 60 at least to perfuse the brain. We need a 60 MAP to perfuse the brain. Your targeted MAP is 60. And again, MAP is a better way of determining organ perfusion. Your brain is an organ, right? You need a MAP of 60 for this to be a good outcome. How's that sound? Good? Great. So that's pretty much the same thing on a different slide. So you can just read that at your own leisure if you want. Way. Ventilatory support, blah, blah, blah. So same thing, different day. Is it possible to be hit in the head and have amnesia? Yeah. Retrograde, you cannot recall events before the injury. That's retro, throwback, behind. All right, so antegrade amnesia, amnesia that exists after recovery of consciousness. You cannot create new memories. All right, that's the difference in the two, know that. All right, so epidural versus subdural bleed. This is a good slide here to remember because there are differences in the head bleeds. Now, epidural is a rapid arterial bleed. Epi, meaning outside, dura, dural matter. It's between the dura mater and the skull. This involves arteries. The most common artery involved in an epidural bleed is the middle meningeal artery. I have seen that on a registry test that I have taken. The most common is the middle meningeal artery. If you remember nothing else I say about epidural bleeds, remember that it's arterial in nature, it's fast, they can have signs and symptoms very rapidly, and it is most commonly from the middle meningeal artery. So what about subdural bleeds? These are bleeding within the meninges. Bleeding within the meninges. All right. So beneath the dura mater and within their subarachnoid space. Above the pia mater. This is a slow bleed. It could take days to hours. They'll slowly deteriorate and have decreased mentation and have problems. Here's what I want you to do as the provider. Again, you don't have X-ray vision, Clark Kent, so I want you to try and take every patient with a head injury to the hospital for a CT scan. I was working in the Buckhead district one night here in Atlanta, and this guy got hit in the head with a bottle. And on the outside visible, it was just like a little lack right here. And, you know, he just had a little bleeding, and we controlled that within seconds of being there. But I don't know, man, my spidey sense was tingling, and I just have always kind of had that, again, keep that high index of suspicion until proven otherwise. I mean, I got dirty too, man. I talked this guy into going, like, I said, you got kids? He's like, yeah, well, I'm like, you may never see him again. You know, we've got to be sure, man. Let's go get checked out. We took him, got him checked out. They did a CT scan. The dude had a bleed. He had a subdural hematoma bleed. And while it wasn't major yet, it would have been if he'd have gone home and slept on it and woke up the next day. He would have woke up. He might have woke up dead. He could have woke up dead or not woke up at all or whatever you want to call it. But that's again what I'm telling you is fight for your patients. Fight for your patients. I'm dirty with it. I don't care. I mean, I'll use the kids against them. You know, I like what's one elderly lady. I was like, she was refusing going to the hospital, refusing. So her granddaughter was like, and her granddaughter was like 20 something. It wasn't like I was picking on a kid, but hey, go ahead and tell your grandma that you love her and that you want to see her make her next birthday and blah, blah, blah. You know, I'm dirty. I got her granddaughter on her and she went there and got her to go. True story. Does that mean that it always works? No. That does not always work. I have begged people to come to the ER with me because I knew that this was a bad situation. But if they knew who they were, where they're at, what they're doing, they could answer my little neuro assessment. I called the med control and let them talk to a doctor himself or herself. Still don't want to go. I cannot kidnap people against their will. So that meant that I made it 5 minutes down the street and then I had to turn right back around and work an arrest because they chose that. I had one lady tell me, I can afford to die. I cannot afford another hospital bill. I was like, healthcare, cut me deep with that one. I believe it. She had life insurance, but she did not have the capability to pay her already mounting hospital bills or whatever it was. But that kind of struck a chord in me. But still, I'm telling you, please fight for your patients. We don't have x-ray vision. We just have an index of suspicion and we just have gut feelings. And I'd rather do it, get them there, get them checked out and be wrong than not do it and they be dead. That's my 2 cents. I gotta leave it. All right, so spinal cord injuries continue. We got axial loading, which is what? Compressing the spinal cord in direct pressure. So that's compression fracture. The spinal cord is this, we squish it like this. All right, so central anterior and Brown-Séquard cord syndrome. I have seen these on registry tests for probably 12 years now. Okay, I've seen them for a long time. Okay, know the difference in central cord, anterior cord, and Brown-Séquard. So central cord would be hyperextension cervical injuries, greater impairment of the upper extremities than the lower, could have paralysis of the arms, sacral sparing, and stuff like that. Now, anterior cord, usually seen in flexion injuries, right? Decreased sensation of pain and temperature below the lesion, stuff like that. So know the difference in those two. So Brown-Séquard syndrome, hemitransection of the spinal cord. So if you look at the spinal cord like this, right? This is like me standing up straight, like right here. That means the spinal cord is hit on either one side or the other and will cause paralysis or issues, weakness on paralysis on the side that it's hit. So the ipsilateral side. The couple of times I've seen this would be like a gunshot. Somebody got shot in the spine and only hit like one half of it, causing them injuries. So some of the big words such as hemitransection or hyperextension and flexion, that's the big takeaways here. Central cord, hyperextension cervical injury, anterior cord, flexion injury. Brown-Séquard is a hemitransection injury. Make sure you know the difference in those for your registry test. All right, so spinal column injury. We got subluxation or dislocation. All right, so fractures are what? Breaks or damages to the bones, right? So spinous process, transverse can happen. The pedicle, the lamina, the vertebral body could be unstable. My advice is for any kind of spinal, and again, we've stopped backboarding everybody through the years. We found that a curved body on a straight board with no give sometimes causes more problems than it fixes. But for any patient with any type of spinal injury or high index of suspicion, yeah, I'd backboard them. I'd do it to be safe, to protect them from paralysis and prevent secondary injury. That's what we splint for. That's what we're doing. I want him to not have secondary injury. So that is one of the reasons that we would splint or put a spine board on or a C-collar to protect our patients here. All right, burns. Burns. So what we're talking about here is that they're very common. They happen all the time. So second leading cause of death of children for ages less than 12 or greater than 12. Half of all tap burns occur to children that are less than 5. So second leading cause of death for children greater than 12. Half of all tap burns occur in children 5 years or less. So who's at risk? Very young, very old. Firefighters. Well, they do go in there and play with fire. Metal smelters, chemical workers. There are different types of burns: thermal, electrical burns, chemical burns, radiation burns. So knowing these little nuances here will help you. So thermal burns, heat changes the molecular structure of the tissue. Molecules begin to move faster and faster, which causes the denaturing of proteins. Extent of damage is how long were you under that? Duration of contact, so concentration of heat, was it widespread or concentrated, and how hot was it? Temperature matters. And there's also zones, Jackson zones of thermal wounds. The zone of coagulation, cell membranes break, blood coagulates, proteins denature. Zone of stasis, adjacent to the zone of coagulation, less damage, however inflamed, decreased blood flow there. And the zone of hyperemia, it's just redness, more like a sunburn at this point. So know the difference in your burn degrees, like first degree, second degree, third degree. First degree is superficial, man. It's like, it could be a sunburn or something like that. Mainly just the epidermis, the outside layers, it's got a little burn, little blister. Heals a couple of days, not a big deal. Second degree burn, intense pain. This is the very, 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 very painful one. Skin will be white to red blistering. It involves the dermis and epidermis, and it will have usually those big fluid-filled boils covering it. Now, third degree is what we call the full thickness burn. So first degree superficial, second degree partial thickness, third degree is full thickness. The skin has become dry, leathery, it's white, dark brown, charred. This one's pretty much painless because you've burned all the nerves out of that. It's gone down that far. All right, then we got fourth degree, which is involving muscles and bones, charred appearance, it's painless. Knowing your rule of nines, my goodness, this is definitely registry-esque. Know your rule of nines to treat these patients for your registry and for your patients you meet in the field. You need to know how much fluid to give them so that you don't over fluid them. Is that a word? Fluid them? Whatever. So you don't give them too much fluid. So make sure you give them the right amount of fluid by doing what? Knowing the rule of nines for your adult and pediatric patients. I can almost guarantee you that some of you will have burn questions on your registry and you will need to know your rule of nines. Also, for you paramedics, you need to know the Parkland burn formula, which is 4 mLs times kilograms, their weight in kilograms, times the total body surface area burned. Where do you get the total body surface area burned? By following the rule of nines. So if my guy's head is burned, that's 4.5%, right? And if his arm is burned, that's 4.5%. So we got 9% burn. So we would calculate how much of his total body surface area is burned. Okay, so formula again is 4 mLs times their weight in kilograms times total body surface area burned. That gives you how much fluid they get in the next 24 hours. We don't normally have patients for over 24 hours. So the first half we give over the first 8 hours, second half over the next 16. So we would want to dull that out and just give them the first 8 hours, right? So we just give them the first 8 hours there. All right, what about other burn toxicology issues? It's not just what's burning you, it's what's burning inside you, what you're breathing in. So we have carbon dioxide and cyanide poison being very common and very dangerous. So all burn patients are toxic until proven otherwise. All burn patients are toxic until proven otherwise. They've either gotten cyanide or carbon monoxide breathed in. So the thing we have here in the fire service is what, years ago, the thing we have here in the fire service is it ain't like it used to be. Houses used to be made of brick and wood and all that. But nowadays, man, all these synthetic plastics and PVC pipes and polybutylene pipes in the house and stuff, when they burn, they release a lot more dangerous and caustic chemicals that could hurt, kill, choke people out. My firemen are in danger of it, and so are you, the public, if you are in a house fire. So anybody that's been in a house fire is likely to have sucked in some of that air that's toxic. So about 35% of burn patients will have cyanide poisoning. About 35% will have cyanide poisoning, right? So that is a thing. So carbon monoxide poisoning. Carbon monoxide has a higher affinity for hemoglobin and displaces oxygen. So on your red blood cells, you have what's called hemoglobin, and they transport oxygen and they deliver that to your tissues. But carbon monoxide has a higher magnetic attraction. It may not be magnetic, but it is more attracted to the hemoglobin than oxygen. It'll actually jump on there and kick the oxygen off, and it'll fool your pulse ox. Carbon monoxide can fool your pulse ox because that thing's only detecting if the hemoglobin has anything on it. It doesn't detect what is actually on it. To actually check carbon monoxide levels, and your local fire department should have one of these, you need a specialized carbon monoxide pulse ox that can tell you if they breathed in any kind of that caustic chemicals there. So with them breathing in carbon monoxide and it kicking off the oxygen for the patient could become red, sweaty, could develop tachycardia, and they would develop what's called as a relative hypoxia. A relative hypoxia meaning what? They are now hypoxic, low oxygen in their body and blood because of what? That carbon monoxide kicking their O2 molecules off of the hemoglobin. Now, carbon cyanide, or cyanide poisoning is what? It binds to the red blood cells and blocks mitochondrial production of ATP, causes anaerobic metabolism, and creates lactic acidosis, right? So this is a fatal diagnosis if it happens. And it's also produced incomplete combustion with anything with nitrogen in it, vinyl, plastic, wool, silk. Does that sound like something that's in some of y'all's houses? To be honest, there's some of that stuff in my house. Just being real. You know, so we just got to be aware that if anybody's been in a house fire, they could have possible monoxide or cyanide poisoning going on. So if that's the case, every ambulance and or fire truck should have a cyanote kit. They should have a cyanote kit for you to use on them. And also they should carry hydroxycobalamin, which is basically vitamin B12, but it deactivates the cyanide in the patient's system. So you should have an answer to these problems. In EMS, and sometimes we follow Hicks' law, which is if I give you too many roads to a destination, you could get lost. So some services only carry like one answer to this specific problem. Like there's a bunch of ways to treat, you know, difficulty breathing patients with bronchoconstriction, but like the service around here only carries like albuterol, because if I gave you like 5 options, you might get lost in overthinking it. If you only got one option, you're going with that. So there has to be an answer to this problem. So any patient you have with carbon monoxide poisoning or cyanide poisoning, you need to have an answer for it. So if you're cyanide poisoning, you should have a cyanote kit somewhere. You should have hydroxycobalamin somewhere. You should have an answer to this issue somewhere. You're going to want to transport your burn patients and your cyanide, your inhalation poisoning patients to a burn center. A burn center can handle the issues that will be presented with these burn patients, and it will handle these possible poisonings as they occur. Here in the Atlanta area, Grady can handle all that. They got a burn center, and they got a hyperbaric chamber and stuff like that. So that'll be your best bet around here. I thought this was funny, but you know, it's basically the same thing I said earlier. Hemoglobin, oxygen, but he just loves that carbon monoxide. He would just jump on that. So acid versus alkali burns. Burning process for acid lasts just 1 to 2 minutes. Burn will cause coagulation. So hydrofluoric acid is one of the most corrosive materials known. Calcium gluconate gel topically is the way we're going to answer that question right there. Calcium gluconate would be that reversal agent. If you see a question about that, that is your answer. That is your way to deal with it. Alkali burns, it will continue from minutes to hours. And the burn will continue causing liquefaction necrosis. That is turning the solid tissue to fluid or semi-fluid state. Also, if you've got any kind of chemical burn, just to make sure that if it's a powdery substance, you are brushing it all off. Do not pour water on a powder chemical burn and make it worse and spread it. You will want to brush that thing off before you begin flushing. But for these other types of burns, you got to stop the burning process. So flushing with fluids, and that would be a great idea for you to do that. And again, take them to a burn center where they can get the treatment they need. And if you do have to cover any type of burn, make sure you do it with wet, sterile dressings. Don't put any kind of dry, sticky dressings. Imagine this is burned right here, right? So imagine that I burned my arm in this area, and you put a dry dressing there, and when they go to pull it off later to look at it, they're going to snatch skin and tissue. It's going to hurt. I'm going to hate you. I'm going to hunt you down, call your names and stuff on Facebook, whatever. But it's not a good look for you as a provider. All right, so environmental emergency, we've already kind of talked about. Here's just some more information. This slide was fantastic. I found it on Instagram, and I did not build it. Again, we talked about mild, severe hypothermia. I should probably change the way the slideshow order to put those first slides back here, but either way, you're getting the information. So again, with heat stroke, heat exhaustion, and all that, we've talked about how to treat it, but here's an example of the Osborne wave that can occur with hypothermia. Remember, they're at risk for VFib or if they're in extreme hypothermia. So we need to make sure that we're looking out for Osborne waves. They could be in at risk for the VFib, and also handling these patients that are in hypothermia very carefully. Handle these patients very carefully, because if you jaw around a patient that is in hypothermia, you could cause them to go into VFib by rough handling. So be very careful with that. And my boy Steve Irwin here. I used to love this guy growing up, and I really hated what happened to him. I was very happy to see that his family is still carrying on his work and trying to preserve wildlife and let people enjoy, wildlife like they do. And I saw a Facebook meme that was like, this crazy girl's playing with this dang alligator or something. Then the dude was like, then he read whose name it was, and it was like Bendy Irwin. And he was like, oh, it's you. Okay, just be careful. We love you. And it's true. We do. I always love the Irwin family and just their zest for life, and especially Steve. So that's why I included that picture here. That was off topic, sorry. So hazardous aquatic life. We got jellyfish, sea anemones, fire coral, and of course you got stingrays, which is what got Steve here. You got to be very careful with aquatic life. Here in Georgia, we don't have many beaches, but we do have some over there towards the coast around Savannah, Jackal Island, stuff like that. So never say never. You may move to a spot where you got this. Then again, you may not. But you should know how to deal with these issues just in case you have this question on your registry. Secondly, you should know how to deal with this issue because, well, we do have the Georgia Aquarium here, and I'd hate one of them trainers get geeked up by one of them things. So you just never know. So just being thorough and knowing your stuff is vitally important. So why is it important? Well, sometimes the boy does cry wolf, and you get there and there's no wolf to be seen, but you need to always act like there's a wolf at the door. And this is, a metaphor, but basically I'm saying you need to always act like there's an emergency going to happen, because it will be crying wolf, crying wolf, crying wolf. And when that wolf finally is at the door, if your gun is not loaded, you will not be able to handle the situation. That wolf will eat you and your patient. You'll both get hurt. The patient physically and possibly lose their life. You will have to deal with the emotional toll of that and possibly some legalistic ramifications from that. So even on skills that you don't use very often, train and train and train. So the less frequently used skills that are more high acuity, you should definitely use them more and practice them more and be more ready to use them at any time. I'm gonna be quite honest with you. I have been blessed in my career over 12 years of being in paramedicine. I've never had to do a surgical cric or neocric. Never had to do it. I've always found a way to either intubate or ventilate. I always tell my students, if you cannot ventilate, if you cannot intubate, then you must crackinate. I made that up. You must crackinate. But I've always found a way to either intubate or ventilate For some medics, it's a pride thing. I got to get the tube, man. I got to get the tube. While that is best for the patient to get an endotracheal tube to be airway protective, patients don't die and suffer brain damage because you cannot intubate. They die and suffer brain damage and hypoxia because you do not ventilate. Ventilation is extremely important. And I tell you, I mean, do not let your pride get in the way. If you can't get into endotracheal tube, go with a rescue airway. Go with a blind insertion airway device like an iGel, a King, even that old combi tube. Something is better than nothing. Obviously, I prefer the endotracheal tube. I look really cool going to the ER. Yeah, I got the tube, man. You know what I'm saying? But, you know, some people have, you know, more anterior airways. Some people have, you know, crushed larynxes. I mean, there's just so many variables there. You can't expect to hit every IV. You can't expect to hit every tube. But what you can do is practice and train and make sure you're giving it your best shot. I read a study from IOMED the other day, and it said that the use of a bougie can increase your chances of a first pass intubation by like 96%. So if it was me, I'd buy me a couple of bougies and carry them with me on the truck. And if I needed to use one, I'd throw that thing down there. I mean, whatever works, man, you know, make it happen. So stay up to date on your stuff. All right, now what about these other toxicology issues? We got coral snakes who are poisonous as hail. So they got the 3-color pattern with red, black, and yellow or white bands. These snakes will hang on during the bite. Pit viper will bite you and just move on. This guy might hang on and keep injecting venom. Symptoms will occur within 6 to 12 hours, slurred speech, dilated pupils, dysphagia, which will be difficulty eating or talking, paralysis and death within 24 hours. They need anti-venom. So as soon as you find out they were bit by a snake, try and find out what kind of snake, but don't be trying to grab it and take it with you. That's just too much Daniel Boone stuff for me. So just be very careful with that. So remember this little analogy here, red on yellow, kill a fellow. That's a coral snake. Red on black, venom lack. We're talking about a coral snake versus a king snake now. So the coral snake is red on yellow. The king snake would be red on black. What about ticks? Do they carry any kind of diseases? Yeah, they do. You can get Rocky Mountain spotted fever. You can get Lyme disease. That's the most common tick-borne disease in the U.S. And with Rocky Mountain spotted fever, they'll get small pink spots on the wrist, ankles, then goes to the rest of their body. They'll get a high fever, loss of appetite, all from a tick bite. And again, Lyme disease is the most common tick-borne disease in the U.S. A lot of deer carry, and if you're a hunter like me, you might be careful out in the woods. You know, check yourself for ticks. Over time with Lyme disease, you could have cranial nerve palsies that may occur. You could develop tick paralysis, neurotoxin released by the salivary glands, restless, flaccid paralysis, and respiratory system can eventually become depressed, progressing to death. Those are 3 problems ticks can give you. What are they again? Rocky Mountain spotted fever, Lyme disease, tick paralysis. What about sea life? I mean, this is kind of out of place, but what you're going to want to do is remove the barbs if they're visible. You got a sea urchin or something that stabbed your patient. You want to get that out of there so it doesn't keep injecting venom or causing pain. But general sea life management is you want to irrigate the wound, normal saline, tap water, controlling the bleeding, and put their body part that's been stabbed or stung in the hottest water they can stand. Put that body part in the hottest water they can stand, and then you can use analgesics to mitigate pain, transport, ABCs. That's it. Please don't pee on your patient. I know one of y'all is like, what about peeing on them? Can I do that? No. I can't prescribe you 50 cc's of pee. No, that is not a medical thing. That is more of a, to be honest, I don't know if it works or not, but don't pee on your patient. I cannot explain that to a director. I'm not going to curry that. And we don't prescribe, pissination on patients. So don't pee on your patients. That goes double for anybody from Rockdale County that I may have taught in the last year. What about spider bites? We got old Spider-Man here. We got a brown recluse. We got a black widow. Around here in the South Georgia area, this is pretty common. Well, maybe not Spider-Man. He mainly from Queens, but black widow and the brown recluse are pretty common. So differentiating the two and what their bites do is very important. Registry could ask you this question. To be honest, man, you could run this call quite easily. quite easily. Happens a lot here in the South. So black widow has that red hourglass shape. See the red hourglass over here. Females are the venomous ones. Initial bite is painless, feels like a pinprick. Within an hour, they're going to have muscle spasms and cramps. And the way you deal with the muscle spasm is diazepam or some type of anticonvulsant like your Versed Valium or your Ativan, something like that. You could do lidocaine to numb the site, but the reversal agent for their venom is going to be calcium gluconate. Now, just because you can doesn't mean you should. Remember to adhere to your local protocol, because I can tell you now that none of my local protocol has black widow bites in there about it. Again, I'm prepping you for a kind of a generalized registry thing here. I might be leaving stuff out, you know, and if that's the case, again, I'll tell you right frankly here that even on registry's website, they say that no one source of material can prepare you for your national registry. No one source can prepare you for your national registry. That's a fact, Jack. And if you're a paramedic or an EMT, I would definitely say read your book, but also read other books, talk to some paramedics, download the national EMT or paramedic curriculum guidelines and find out what you're supposed to know and be taught. Download the national EMS scope of practice model that was in, I think, came out in 2019, the newest one. And find out what you can do as far as your national scope of practice, because I'm teaching from the perspective of a Georgia street medic. And some of the things I say might be a bit biased. You got to keep that in mind. So while a lot of things may be universal across the board, like our ACLS and CPR stuff, because we get all that from American Heart, there are some subtle nuances to the way we do certain things from state to state and even from county to county in Georgia. Jackson County don't carry the same drugs as Fulton County, you know what I'm saying? So we've got to be aware of what we're doing here. I made my students do a drug box project because it's your job to know your EMS system, the hospitals you transport to, and where you take every patient you can run into, and know your drug box and your protocols like the back of your hand. Even I, as an instructor, if I'm on the truck and I'm about to pick up your kid, even though I know the dose is this, this, and this, I like to measure twice and cut once. Even though I know the dose, even though I teach protocol classes, I'm still going to pull out that old physical book, flip, 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 check the cookbook, make sure my recipe's right before I do it. Now, better paramedics can think critically and operate in that grade. So for the cookbook medic, we still need you, we still love you, but I'd rather you be a good chef and know when to sprinkle some here, when to withhold, because some patients, given the standard treatment that your book protocols say, could hurt them more. So it's very important for you to know when and where to sprinkle the magic around, okay? All right, so what about spiders, scorpions, and ticks? Most spiders do have venom glands. We got the black widow, and we never finished talking about the brown recluse. I'm so sorry. So the brown recluse is that old fiddleback spider. And if you look closely up here on the top of this dude's head, see that little line and that little right there? That's why I call him a fiddleback. At the top of his head looks like a fiddle. So that's why they call it fiddleback. He has a little pain when he bites you, but what he has is a more necrotic type of venom. The tissue will be surrounded by an ischemic ring lined by a red halo. And that tissue will be necrotic and it will die off. I have seen several brown recluse bites, and that patient usually does lose some tissue there. Never ran a real bad one, just to be honest. Not that it can't happen. It could kill you, but the patients I've seen had like a bite on their hand or their stomach, and yeah, it necroted the tissue, but and they lost probably about half of a dime size worth of tissue. But once it was treated, I mean, they had a sore there, some pus for a couple of weeks, and then it just made a scar. But I would definitely treat this thing like a true blue emergency and get them to where they can get the help they need. Your job is to make sure that the spider's not still biting them, and that you keep their ABCs moving and grooving during transport. So we've already talked about all of that. We do have scorpions here in Georgia. I didn't know that until I moved to the North Georgia area. In South Georgia, I've never seen one, but we actually have these small little inch-long brown scorpions, and they do have venom, but the venom they carry is not like a super toxic. It would more only be dangerous if you were like allergic to some of the antigens in that venom. So that would be, you know, where I'm at with that. Let's keep going. So let's talk about the brain recluse. Got that ischemic ring. Here's the bullseye. We've already talked about this. That's what the ring would look like. A bite there, it gets bigger and bigger, and that tissue would die off. And that would be the problem that the brain recluse guy runs into. That would be that problem there. So reptile bites, we talked a little bit about snake bites, but we mainly just spoke about coral. So here in South Georgia and North Georgia, in the South, we've got pit vipers, rattlesnakes, cottonmouth, water moccasins, copperheads. And I'm sure that y'all got snakes in other parts of the country too, if you're watching this, or it might just be my students that watch it. I don't care. Somebody's watching it. But with these kind of guys, we need to identify the snakes, make sure that the scene is safe. I can tell you right now, I call it Gradations 1-9 because I developed this at Grady Hospital working for their 911. If the scene's unsafe, thou shalt dippeth the hell out. So if there's a snake there, your boy's gone. Shoot, I'm out. I don't play with that kind of stuff. I don't normally have the type of the type of tools I need to deal with a snake on the ambulance. Now, if I was in my personal vehicle, I could deal with it right quick, fast, in a hurry. I could deal with a herd of them. But on the ambulance, I don't have that type of tool set. So if the scene's unsafe, dip out of there. But the kind of venom they have will cause hemolysis, so red blood cell destruction, intravascular coagulation issues, convulsions, and acute renal failure. You'll want to maintain ABCs, get some IVs, extremity, immobilize it in a neutral position. Do not use ice packs or tourniquets. If anything, I would say possibly, if you're going to put anything on it, only put something on it that would impede the lymphatic flow, but not the arterial or venous blood flow. You're going to want to put the time that they were possibly bit, and you're going to want to go ahead and call the ER and get them to work on the antivenom. So from what I've been told by a pharmacist friend of mine is that they just have to mix it, and it takes some time. So the sooner you find out you've got a true blue snake bite and get them working on that antivenom, the better outcome the patient will have. All right, so fractures. We need to know what types of fractures there are and be able to identify them. So we have transverse, as you can see over here, is we got a fracture right down across the middle. Oblique is a cross fracture. Spiral is a twisting fracture. Comminuted is a crush fracture. Segmented is 2 breaks. Impacted was it was squished and broke. A torus is where it's got a big bulge there. And a green stick is most commonly seen in children. It's most commonly seen in children, and it's due to their spongy bone. It's only a partial break. It's only a kind of a break. All right, so we also have ligaments, tendons that can cause sprains and strains. Ligaments are what connect bone to bone. Tendons connect muscle to bone. It's important for you to know that. So a sprain will be stretching and tearing of ligaments, and a strain, overstretching and exertion of a muscle in their tendons. So with breaking bones, you do have fluid loss, right? If I break bones, I'm going to lose blood volume. All right, it will be usually, if it's an internal fracture, open versus closed fracture. Open meaning what? That it's a break inside and the bone's not sticking through the skin. Now, a open fracture is what? The bone is broken, stabbed me through my skin, and it's exposed to the outside world. So with breaking bones, I could lose blood volume. With a rib, I would lose 125 mLs. Radius or ulna, I could lose 250 to 500 mLs. The humerus, not funny, 500 to 750 mLs. Tibia or fibia, 500 to 1,000. Femur is worth 1,000 to 2,000 mLs. And with your pelvis, you could lose 1,000 plus mLs. So with hip fractures, the affected leg could be shortened and rotated. So shortening and rotation, we're talking about either medial or lateral rotation of that limb. So when that happens, the leg will be shorter than the other one that's not affected, and it will be either turned in or left or out. It will be angulated in a funny way, and you will be able to see it. You must note it, see it. And again, with any kind of trauma, you need to cut their clothes and check for other injuries. Check for other injuries. All right. So we've already talked about hip fractures, dislocations. And to be honest, it might be really hard to differentiate in the field from fracture versus dislocation. We would treat it the same, basically, though. We would give them something for pain. You'd want to use a scoop stretcher and not roll them and make it worse, and get them to a trauma hospital so it can be worked on. You need an orthopedic surgeon, not you. So that's what we're doing. Femur fracture. The leg is shortened, rotated, mid-thigh swelling. Again, we just want to make sure that that's being taken care of. All right, so vehicle versus pedestrian. Here we got pediatric versus adults, and their presentation could be different based on you know, their body size, structure, and their actions of normal impacting, right? So children tend to face the oncoming vehicle. They don't really, especially young children, like deer in the headlights, they don't know much or any better to get out of the way, right? So that'd be you know, how they would do it. So the kind of injuries we're looking at: frontal impact injuries above the knees and pelvis, initial impact, femur, and pelvic fractures, internal hemorrhage. Secondary impact, when they're thrown from the vehicle, when it hits them, it's going to launch them, right? So thrown backwards, head and neck flexing forward, abdominal, pelvic, and thoracic trauma, facial, head and neck trauma. And the third impact is when they hit the ground again. And the child may be under the vehicle, may be drugged or ran over the wheels, and usually not a high prognosis for recovery. So adults, they try and get away from the vehicle, most of them anyway. They turn away from the vehicle. I know here in Atlanta, we have a big urban camper population that likes to jump in front of vehicles. I've had him do it in front of the ambulance, and while I didn't hit him, I came pretty close. So we've got that going on for us. So the adults will normally turn away, so have lateral or posterior impact, so either side or back impacts. Usually the bumper will strike lower legs, and lower extremity fractures will happen. And so we got that going on. Adults will hit the hood, and I've actually seen them launched and flipped over the hood before. And injuring the spine, the intra-abdominal area, thoracic, all that good stuff there. When they strike the ground, hip, head, shoulder, something, they're going to have a lot of issues going on there with that. So we have types of impact. This is important. The registry likes these type of questions here. Down and under. So patient was thrown under the dashboard, and knees, part of the body, legs absorb most of that impact, patellar fractures, femoral fractures, hip locations, you know, any kind of injury you could think of from being thrown under a dashboard. Chest wall could hit the steering column or the dashboard. And with that happening, you could develop a tension pneumo, you could pop a lung, especially if they're holding their breath. It could be like paper bag syndrome. You could pop that lung real good. So being very thorough, again, is a real key. And not only being thorough for the moment, but assessing, reassessing, and then as you continue being that patient is in your care, continuously reassessing, because things develop over time sometimes. Up and over pathway, body strikes the steering wheel, ribs and underlying structures absorb that momentum, rib fractures, ruptured diaphragm, hemopneumos, contention, pulmonary contusions, cardiac contusions. If the head strikes a windshield, we're looking at spider webbing of the windshield. You can suspect some cervical fractures, a head injury, possible internal bleeding. You just never know with these type of injuries. So you got to be very acutely aware of the mechanism of injury and the clues that it gives you. If I've got spider webbing, I'm thinking, hey, he hit his head. I need to be thinking about head injuries. I don't need to get distracted by that. I still need to be thorough and go head to toe, head to toe, head to toe. Even when I'm doing my reassessment, go head to toe. But I have an index of suspicion of a possible head injury. What about a patient and there's a bent steering wheel? I know that chest, it hit the steering wheel, so I need to be thinking some thoracic injuries too. So we've got that going on right there. So we got lateral impacts hitting the car. That's from the side. You got to think about what side was hit. So that lateral side of your body will have damage done to it. You know, so we got pulmonary contusions, liver, spleen, neck injuries, rotational impacts, rollovers. Man, you could have just any kind of injury. With rollovers, I mean, if you're not strapped in, even if you are strapped in, you're going to be hurt. And secondly, we've got ejections, which will just throw the patient out of the car, and it will cause monumental damage to them. Rear end, you're looking back and neck injuries, hyperextension, that whiplash kind of stuff going on. Motorcycle crashes. I read a thing that said they are 37 times more deadly. And that's obviously because there's no vehicular structure there to protect them. I've never worked a motorcycle wreck that wasn't bad. So with that, we've got angular impact. We got the patients being thrown. The only way that they really can walk away is if they're smart enough and they have the time to lay that bike down. That's going to cause massive road rash and abrasions and maybe some fractures, but it may save their life. Usually if they're hit by a car, it's bad. I already spoke about compartment syndrome and flail chest. Here's just some more information on it. Just good slides I found to help with you visual learners and all you reading learners too. Flail chest, we talked about it. Sternal fractures, we talked about that. So some information about the needle chest decompression that we want to use a big size needle, at least 3 inches, 3.5, 3.25 inches. Insert above the rib. If you go below the rib, there's a neurovascular bundle there, and you could slice it and the patient will bleed into their chest. Historically, we would do a mid-clavicular line, second or third intercostal space over the rib. Updated evidence from the new PHTLS 9th edition. We're looking at the 5th intercostal space, anterior axillary line being the updated secondary space for our needle chest decompression. So keep that in mind in case Registry has updated to the 9th edition of PHTLS, which is pre-hospital trauma life support. And that is our trauma review. Again, it's not all inclusive, but it's a good review. It's got all the information that we need here to deal with these type of injuries. Remember, it's a surgical disease. Find the problem, identify it, but do it en route, 10 minutes or less on scene. Fluids, we're looking at keeping that blood pressure at least a 60 map, maybe a permissive hypotension. But again, follow your local protocol. If your medical director ain't cool with that, do whatever he tells you to do. But again, we've heard a lot of patients by over fluid bolusing patients through the years. They need blood, they need surgery. Any kind of broken bones or splinting, we got a splint, pain management. Don't withhold pain meds. Don't be that guy. What if it's a drug addict? And I know he's a drug addict. It ain't your job to judge him. He's got a broke leg. It's hanging on by a piece of flesh. Give that man some drugs. Our job is to mitigate pain, not to judge. We are objective healthcare providers, and that's going to be it. So that is trauma review for Registry. There's more to it. There's always going to be more to say, but that's all I got for the day. You guys work hard and put the time in. You'll do fantastic. I'll have a good one.